Hey, good morning. How are you? My name is Cassie. I was the student CRNA on this case. We've got here a 4-year-old male with Angelman syndrome. With that, he does have seizures, excessive salivation, tongue thrusting, frequent mouth sucking movements, and irregular limb movements. Surgical history of strabismus surgery. Also does have chronic tonsillitis and adenoiditis, which is the purpose of our procedure today. For the chronic tonsillitis and the adenoiditis, he received a tonsillectomy and a adenoidectomy with bilateral myringotomy tube placement. Anesthesia technique was general anesthesia. Access was a 24 gauge PIV on the right foot. Patient does have allergies to soy, dairy, and IV fluids with glucose. The increased glucose is thought to increase his propensity for seizures. Pre-op, we had given him 12 milligrams of Versed, 150 milligrams of acetaminophen (PO), and then in order to induce, we gave him 8% sevoflurane and 70% nitrous oxide. IV, in order for induction, we did give 100 milligrams of propofol, 10 micrograms of fentanyl, 25 milligrams of lidocaine, and 0.2 milligrams of glycopyrrolate. And then throughout the procedure, patient did receive lactated ringers without dextrose for fluid maintenance. Intubation itself was fairly easy with a Miller tube blade and a 4.5 ET tube. Patient was extubated prior to arriving here. Airway reflexes were confirmed, and we will be bringing him to the recovery unit with a blow-by oxygen. No drips are needed for this patient at this time. Treatment plan post-op will be pain control and monitoring his airway status. Our current vitals, prior to the case, our vitals were heart rate of 113, blood pressure of 99/35, saturating 100% on room air, a temp of 37.1. During a case, vitals did not deviate 20% from the baseline. And then most recent vitals were a heart rate of 100, a blood pressure of 100/40, satting 100% on that blow-by oxygen, and temp is 37.1 as well. Fluids, like I said earlier, were just the lactated ringers without glucose for maintenance. No blood products were administered. Intra-op, fairly uneventful procedure. Patient did have some light bucking when the second tonsil was being excised. We gave 20 milligrams of propofol, 5 micrograms of fentanyl, 15 milligrams of lidocaine were given. For the most part, the patient was kept on pressure support of 12, mainly between 5 to 5.5% of desflurane, and the nitrous oxide at 70%. No recent labs were drawn for this patient, and then our suggestions for immediate post-op care would be, like I said earlier, pain control. Patients with Angelman syndrome are relatively insensitive to pain, so the parents have been brought to bedside. Well, they have been asked to be brought to bedside fairly quickly, so that they can monitor the patient for the patient's normal signs of pain. Additionally, upper airway obstruction can be a complication with patients with Angelman syndrome, especially in the recovery area. So just be mindful of this and watch for airway distress. I would also be mindful of the patient's positioning and padding. Patients with Angelman syndrome tend to have hyperactive lower extremity deep tendon reflexes. If mismanaged, it can lead to overstretching and compartment syndrome. Patient does not need ICU care, and it should be discharged today. If not, for interprofessional healthcare providers I would consult would be 1 PT for maintaining patient's physical mobility, occupational therapy for his ADL care, and speech pathology also, just to see if the patient can swallow appropriately and will not aspirate, as well as a medical geneticist to help manage the patient's genetic condition and assist the patient, mainly parents as well, for any further questions that they have. Thank you. If you have any questions, let me know.